Welcome to episode 161, Kink, Laying the Clinical Groundwork from Fundamentals and Beyond, featuring Elyssa Helfer, licensed marriage and family therapist. Make sure to subscribe to learn about future episodes. By Clearly Clinical, learn, grow, shine. Hello to our listeners. My name is Beth Irias, and today we're going to talk about a topic that, goodness, everybody is excited to talk about or listen to. We're going to talk about kink, and today I'm delighted to be joined by Elyssa Helfer. She is a licensed marriage and family therapist in the states of California, Colorado, and Florida, and her jam is really sexology and particularly studying and discussing kink. Thank you so much for joining us, Elyssa.
Thank you for having me. I'm so excited to be here.
So why don't we start by you sharing how you came to start doing this particular very niche work?
Sure. Well, this work kind of found me. I definitely wasn't seeking a career in studying kink because I didn't really know what kink was when I was in college. And once I discovered it completely by accident by attending a conference that was being held at University of Minnesota, I learned about kink and I immediately fell in love. I thought it was the most interesting thing I had ever seen. And the people at the conference just seemed so open and adventurous. And that's really where my journey began. And so I guess prior to becoming a therapist, I had this idea that I wanted to know more about this community.
And you teach at Antioch University, and you've also been running studies about kink, and I'm sure we'll talk about that during our conversation today. Why don't we start by you just even defining what kink is?
Yeah, so kink is interesting because there really doesn't seem to be one perfect definition. The way that I describe it is that it's this umbrella term that encompasses many different types of erotic play or erotic desires. And so something like BDSM is actually separate from kink in that it goes like under the umbrella. So kink overall looks at what someone would call it like non-conventional sexual desires. Although I'm not crazy about that terminology.
I can imagine why, but why don't you elaborate? Why are you not crazy about that terminology?
I think that the society at large imagines that there aren't that many people that practice kink. And to be honest, I think that there are a lot of people that practice kink who don't even realize that what they're doing is considered kinky. And so being stuck in sort of this Victorian era view of what sex is, right? Heterosexual and vanilla and monogamous. Being stuck in that view, to me, it just really doesn't encompass what the reality is, which is people are participating in this. And if they're not participating in it, they often have desires or fantasies about it.
And kink in our culture is sometimes almost synonymous with shame. And I know I've seen that in therapy, that when this topic of sex and sexual desire comes up and then somebody's eyes go down to the ground and their posture changes and then they're like, well, yeah. I kind of like it when, and then they're looking at you waiting for you to be like, oh. Tell me about why you think it's really important that clinicians are having a conversation about kink and that we become better educated on the topic.
Gosh, I could talk about this particular part of it for hours, but I will try to keep it concise. Our duty as clinicians is to be there for our clients, to enhance their lives, help them in the ways that they need. And I think that when clinicians are showing up into a therapeutic space without being properly educated or perpetuating harmful myths and stereotypes, we're actually doing what is the opposite of kind of what we've all vowed to do. We're practicing unethically and we're causing harm to our clients. One of the things that's most heartbreaking for me as a clinician is when someone comes to me and I'm the third, fourth, fifth therapist that they've seen because the others, either shamed them, refused to work with them, conflated their kink play with abuse. The experiences that are happening that not just that I've seen in my own practice, but they're reflected in the research. And so it's really important for me to be on this journey to really promote clinical education around kink.
What are some of the most important research points about kink? Like, as you said earlier, it's one of those things that people think is much more underground, a really small minority participating or interested in. Can you kind of correct some of those myths?
Yeah, I mean, well, first we have to talk about numbers. So there's a lot of data on how many people are participating in kink, and pretty much all the research says something different. I think this is because it's sort of hard to define kink. And if we're being honest, I imagine there's a lot of kinky people out there who don't want to participate in research. So the research right now shows somewhere between like 2 and 25% of the population is actually engaging in some sort of kink practice, but that up to 65% have at least one fantasy about it. And so we got to remember, how are we defining kink? For some people, doing something like spanking is not considered kinky, but to some others it is. And so we have to look at like, well, what really is kink? So first and foremost, people are kinky. People have alternative sexual practices. And then we need to look at, well, how often are they going to therapy? And there's this kind of big study. I want to say it was in 2012, and I think that I sent you the reference for this one, where they looked at 766 clinicians, and they found that over 70% had worked with a kinky client, but that only, I believe, 48% felt like they were confident and competent to do that type of work. And so these numbers actually came up in my own research that I've just been doing, where there are more kinky people being seen than clinicians who are feeling competent working with that population. And that gap is something that we really, really need to fill.
When we get in the territory of not being kink informed, kink competent, if you will, what are the risks? I mean, there's a big file for us to open up here about the puritanical origins of how we view sex in the United States. Without doing the huge history lesson, can you kind of talk about where kink and shame became kind of best friends?
So when I teach this to my students, and when I do like various lectures, I usually talk about the daddies of pathology, which are Freud and Richard von Krafft-Ebing. The two of them really sort of uncovered not really uncovered, but they put the spotlight on kink as something pathological. So in the late 1800s, Richard von Krafft-Ebing, he went out and published Psychopathia Sexualis. And in that works, he talked about how kink is very problematic. It needs to be eliminated. These people are degenerates. And if they don't eliminate their kink, they're going to pass it on to their children. And so he started to really introduce kink into the sort of like the medical lexicon. And Krafft-Ebing, interestingly, coined the term sadism and masochism. And Freud later in, I want to say it's 1906, that's when he released his work sort of confirming what Krafft-Ebing was saying. And so the two of them, while they didn't necessarily work together, they had a lot of these really pathologizing views about what kink was. And that view has really stuck around up until, especially when the first DSM was released in the early 1950s and further to now.
Can you speak more on how kink is pathologized in the main lexicon and society that we exist in? And so for our listeners, we're recording this interview in July of 2022. And as Elyssa and I were discussing before recording, we just had Roe v. Wade overturned within the last month. So sex and reproductive access are like at the front of people's minds, and it's just a really interesting time in history.
It absolutely is. And for those who participate in kink, they're not protected. There's no like legal protections for people that are kinky. And when we look at the media representation of kink, if I asked just, a person on the street, like, what's the first thing you think about when you imagine someone who's kinky? They'll be like, oh, like a person head to toe, leather. And, there's this visual that we have that I think is based on the media. And something that's really interesting about the media is that it portrays kink in, I think, kind of one or two ways. It's either this person is very sick and something's very wrong with them, right? Like they're like the murderer on SVU. Or it's something like 50 Shades. And I mean, we all know that that wasn't accurate whatsoever, but it will present them in sort of this way of like, well, you can forgive kink because the person is so broken and like so hurt. And both of those visuals are really pathologizing, right? It either means that kinky people are sick or that they're broken somehow.
For you, having analyzed this research and looking at kink's place in society, why is it so important for clinicians to be more competent in discussing and working with kink?
Well, first and foremost, because they need to learn what the realities are. A lot of folks will conflate kink with pathology and uphold this assumption that kinky people somehow experience, mental illness at higher rates, or that they're inherently more traumatized, or that their kink is a result of some sort of trauma, where the research time and time again shows us that that is just simply not the case. There are, individuals who are kinky tend to be well-adjusted, when they're doing, they've done some research on personality traits, and they tend to be less sensitive to rejection and lower on neuroticism. And so really there are a lot of positive outcomes that kinky people experience, but because of this deep-rooted sort of sex-negative culture we live in, it's almost like we have these blinders on where we're not looking at the reality that kinky people who really engage in kink in this healthy, consensual way, they're not sick, deviant, twisted, mentally ill. It's just not true.
I think of anything you're going to say during this episode, I think that's the one that I'm like highlighting with like a line underneath it of just this idea that kink doesn't necessarily and doesn't always point to some idea about pathology. And speaking for myself as a clinician, that's absolutely something I've heard people bring up before, which is like, well, I really like this thing. Is that because I experienced some abuse that I don't know about? And there's this fear where, you use the word deviant, where it's like, there must be something wrong with me that I like it when someone does this, or I enjoy this particular aspect. And these ideas of what I remember in my diagnosing class about the philias, the paraphilias of like, what are the philias? So your reaction there, tell me how you feel about the philias.
I have very, very strong feelings about the philias. Now, in 2013, there was a major shift when it comes to the DSM. When the DSM-5 came out, it shifted the diagnosis from paraphilia to paraphilic disorder. And so to sort of clarify what that means is that now someone has to have not just a paraphilia, but a paraphilia plus personal distress that's not necessarily related to societal, negativity or stigma. But how do I feel about it? I would be thrilled to see paraphilic disorder completely eliminated from the DSM. I think that putting it in there is incredibly pathologizing. I think that people shift and change, and maybe what is distressing to someone at 19 years old who's never experienced kink in their lives, that might not be the case a decade from then. And so to be sort of put in this category that there's something wrong is really harmful. Now, I heard this example, and I'm totally going to botch exactly how it was said, but it was from Dr. Anna Randall. I was listening to her speak, and she was talking about crime, and it really, like, how there's sort of this conflation of criminal behavior and like non-consensual behavior and kink. And what was really fascinating to me was this idea of like, well, why is it that if somebody goes and robs a bank and they have a weapon with them, like no one in that space consented to being in an environment where there was a weapon. No one consented to that, but that's not in the DSM. But if somebody walks into a bank and flashes them or gropes somebody, which is a crime, right? Fraudulentrism, which is essentially like groping, is a crime. But for some reason, because it's attached to sexuality, now it's diagnosable, now it's pathological. So that whole concept has always been really fascinating to me. Like, well, then why is it that somebody who goes and commits another type of crime that's not related to sexuality, why is that not in the DSM?
That's a really interesting point. And you, I think more than the average bear, so to speak, have spent time wondering about this. And can you just talk for a minute? Where did this come from? Because if we look back at history, if we look at Mesopotamia, if we look at ancient cultures, there's plenty of kink reflected. Like, this is not a new phenomenon. This is not a new part of being human. But what happened that made it so like, oh, what? Up until 50 Shades of Grey, which, at least on some level, people started talking about it more. But up until then, it was like, oh, no.
Yeah, so a lot has happened through history. And gosh, like, when did things change? I think the Victorian era, I think the 1800s was a really, really big shift. And what's interesting about kink history is there was sort of this difference between the history of sexual pain, so like masochism, for example, and sexual submission. So sexual pain, that has been around for a really long time. Sexual pain is even described in the Kama Sutra. And interestingly, that's kind of the first time that the question of ethics starts to come up, right? The Kama Sutra states, and this is not a quote, but something like, people who engage in this need to be wanting to do it. That's where they kind of put the pain and pleasure together. And I think that, when Krafft-Ebing released Psychopathia Sexualis, it was not necessarily, I don't think, just based on what I've read, that the intent was to cause this massive stigmatization thing. He actually released it because he was saying, these people are not insane. They're just like sick. Something's wrong with them. Because prior to then, when someone was viewed as insane, there really wasn't a whole lot that you could do about it. It was kind of like, this is just what they are. But I think moving it into the realm of pathology allowed it to have this opportunity to be quote unquote fixed. And so I think it was just the boom of psychiatry, and conservative ideals. I think that's sort of what happened. I mean, really, until the American Sexual Revolution, sex was just, it was there was secrecy, and there was some disgust, and it needed to look a certain way. And the DSM, right, the diagnostic standards reflected that. The DSM has always reflected the cultural standards, so to speak, of the time.
And you and I could certainly kind of wax poetic about limitations within the DSM. And I think that's part of the reason that it continues to be revised is because we're looking at those frameworks going, well, I don't know about that. And hopefully moving toward a place of more accurate representation of what's happening in our society. But as you're talking about this, what's occurring to me is the intersectionality as well, about how there's this, for lack of a better term, the deviant bucket. And in there, we have kink, we have sadomasochism, so just, within that umbrella, we have the queer folks. And then, thank you, someone added, let's toss in pedophilia. We'll just throw that into that bucket. Sure. Can you speak to that for a minute in this complexity about how all of these ideas got lumped together that are very, very different?
I spent a little time trying to research, in particular, diagnosis and researching the DSM, and I don't quite have a full grasp of how we got to who makes the decisions. I read one article on that, but it didn't really feel sufficient enough for me to speak on the topic. But everything is lumped together, and it's fascinating because fantasy and action and behavior are two entirely different things. A lot of people are not comfortable with the fantasies that they have, and for some, maybe their fantasies is something that if they did do, it would be considered criminal. And so a lot of the work that I do is helping people kind of understand that their fantasies are not what's harmful. What's harmful is acting upon those fantasies. I have no idea how or why something like pedophilia was attached, although I don't even use that language. That's also very, in my mind, very pathologizing. I know that the folks who work with minor attracted individuals don't use that language. But that is very separate from kink. That, like, I have to tell people this over and over again, like, somebody who is minor attracted, that is not a kink. It is not, right? Kink has pillars. There are pillars that sort of build up what kink is. And one of the big pillars of that is consent with other adults. So participating in anything with children is absolutely not what kinksters do. It is not a part of the kink community. No one in the kink world condones it. And so I want to make sure that whoever's listening and whoever I teach forever separates those two things, because they are absolutely not the same.
Thank you. And thank you for covering that, and also even discussing the language, because it is important that we become aware of not only what's in the air around us in society about what words are being used, but then also like what's the clinical implication and what's actually accurate. I'm glad you bring up that point, because there are like these big words and these big ideas that get thrown out, and it's one of those specializations that if you're not familiar with it, it can be confounded, and it would be to anyone's, I think, disservice to be linking these ideas. So thank you for kind of deconstructing just that. So when we're looking at kink, you already mentioned and tipped your hat to the Kama Sutra on this idea of consent. Can you give us some education about how consent fits into kink and really why it's the backbone of what this means?
Yeah, I mean, I think initially, if any clinician is working with somebody who is kink identified, or really anyone in general, consent is everything. Consent is the most important piece of really any sort of interaction in general, but especially in something like kink. And there are various consent frameworks that people tend to use within the kink world. And they started with SSC. So SSC was introduced in the early 1980s by somebody named David Stein. And this was during the time where there was this big sort of advancements in the gay leather scene. And that's when SSC was developed, to sort of say like, hey, folks, we're not doing anything bad. What we're doing, we're being as safe as possible. We are sane. We're not sick. There's not something wrong with us. And everything we're doing is consensual. And the SSC term, I believe that's what I was taught when I was in school, although I can't say that I was really taught a lot about kink. I think maybe it was covered a little bit one day. But SSC has, I would say it's more utilized by the older generation of kinksters, and more so the newcomers are using something like RAC, which stands for Risk Aware Consensual Kink. It was that term was one that Gary Switch came up with in the late 1990s. And that was mostly because of the argument of like, well, is kink really safe? Is anything really safe? And how do we define sanity? So risk-aware consensual kink, or RAC, is kind of what I use more so with my clients and in my teaching, because I think that recognizing what the risks are is really, really important. But I do want to note that when I say that kink is not necessarily safe, I also say that everything is not necessarily safe, right? Driving a car is not necessarily safe, but we take the risk knowing what could come up if we do engage with that.
Thank you for that kind of side note. So you're saying SSC started back in the 1980s with the kink leather scene in the queer community, and then moving forward into the 1990s with RAC, which is Risk Aware Consensual Kink. What does SSC stand for?
Oh, so SSC stands for Safe, Sane, and Consensual. And there are more, for the record. There's Personal Responsibility Informed Consensual Kink, which is PRIC. There is the 4 C's, which is caring, communication, consent, and caution. And that's actually more recent. That was released in 2014. So there's kind of a number of these. And I think, one of the things that I did when I was working on my dissertation is I did this sort of literature review looking at what do kinky people themselves say that they like? Or what are good experiences with therapists versus what are bad experiences? And I looked at a lot of qualitative research. And one of the things that was sort of, that came up over and over was that kinky individuals really liked when their clinician knew about these concepts, where they were able to say, you know, what consent framework do you adhere to? Or are you familiar with different consent frameworks? How can you utilize this to sort of influence the type of play or relationships that you have? So it's something that not only is important, but that kinky people themselves are saying that they actually like their clinicians to know in a therapeutic space.
So when we're looking at these frameworks, are these frameworks that are, I guess, applied clinically to conceptualize, or is it more framework within the community to self-identify and, I guess, set boundaries around, as you said, safety and risk, or both?
It's more so for the community themselves. I think that, so something that I do as a clinician is I feel like I don't really practice from a vanilla lens. I practice more from a kink lens. And so to me, a kink lens means that ongoing consent is really important in my clinical work. So I personally do utilize these where I will say to my clients, you know, if something hard is about to be talked about, I will say, you know, I have something I want to bring up that might be a little bit difficult to hear. Are you comfortable with me sharing? Like, I'm consistently asking for consent within my sessions. And so that to me is sort of like the way that I implement that into my work. But mostly these terms are founded by and utilized by the kink community themselves.
You've talked about quote unquote kink therapy. Can you explain more about what that really is? And then on the day-to-day, what does a session look like for a quote unquote kink therapist?
So people are often surprised to hear this. I get this question a lot. And they're often surprised to hear that as a kink therapist, so, you know, someone who specializes in working with the kink community, I don't talk about kink every single day or every single session. Clients will come to me because they know, hopefully through referrals or through, you know, seeing some of the work that I do, that I'm not going to sit there and judge them or shame them. So kink is just a piece of their identity, and they don't want it to be some big thing. They just want someone to understand that part of them and their relationship. So when I work with kinky couples, for example, we don't always work on their dynamic. Sometimes we do, but for the most part, it's just that they want someone who understands that they participate in this type of life, and they don't want me to sit there and be like, what is it that you do? That's terrible, or have any sort of judgment towards them.
I appreciate your answer and can definitely relate as someone who works almost exclusively with the queer community. Yes, that's what I know. That's my confidence. And also sometimes very little of our session, if at all, does that ever come up. But it's just this idea of like, this is, I guess, a deliberate, not advertisement, but a deliberate statement of inclusion. But I appreciate you explaining that, because that in and of itself, I could see how if someone misinterpreted the term kink therapy, then it becomes, oh, well, someone who participates in kink needs therapy.
Yes, absolutely. And the reality is, like, most people that come to me, it's because of like job stress or relationship problems. It's not. Now, some people do come specifically because they're sort of newcomers in the kink scene, and they're trying to understand their identity, or they're trying to understand better ways to integrate into the community. So I do quite a bit of that work as well. But my whole goal is that anybody who ever decides to work with me does it because they know that I will create as much safety as I possibly can for that piece of their identity.
Can you speak more on that? I mean, as we're having this conversation, we just had this huge shockwave ruling about reproductive rights for folks with internal reproductive organs. And to me, these ideas kind of crash into themselves about just sex in general, a person's right to sex, particularly people with internal reproductive organs, about like, oh, you can't orgasm? Meh, sucks for you. You know, like the way that the medical establishment often views sexuality. Can you speak a little bit about how you see these pieces fitting together and kind of where therapists come in to creating this, I guess, whole person version that includes potentially sexual identity?
Yeah, I mean, I have really strong feelings about the way that sex is discussed in our educational systems. I think it is almost entirely overlooked and when it is discussed, it is mostly about maybe some physiological stuff. They'll talk about protection, like, STIs. And we almost never hear about programs discussing pleasure, programs talking about alternative identities. When I started teaching at Antioch, I was so floored with their openness in allowing me to talk, to teach a class on working with sex workers, to teach a class on indigenous sexualities, where I got to bring in this excellent guest speaker. And so it's just like the educational system, because of the requirements for human sexuality training, it does not specifically state that we have to talk about alternative sexualities. And for many states, it doesn't require sexuality training whatsoever. So there's so many realms that need to be assessed. And, you mentioning sort of like medical system and mental health systems at large. One of the things that's happening right now, which is really exciting, is research is starting to be done, trying to understand the kinky experience within the healthcare systems. That's really exciting and also new. And that research is being done by TASHRA, which is the Alternative Sexualities Health Research Alliance. And so more information should start coming out in the next few years as we start to really understand the kinky experience as a whole, and not just in the mental health system, although that is still vastly under-researched.
Thank you. Thank you for explaining that. When we talk about kink, I think, in addition to this idea about shame or what's okay or not okay, what comes up too is, I think, confusion about where abuse fits in or where that line is. Can you speak to that and kind of clarify that?
Yeah, I like to start by just validating, like, if you're listening to this and you're like, I don't know anything about this, I get it. There hasn't been an opportunity. So I'm glad that you're taking that opportunity right now. So let's talk a little bit about that. If we're looking at the way that abuse exists, and obviously consent is sort of like the factor that differentiates healthy kink and abuse. But there's also a lot of other red flags that I think are really important to look out for when we are working with kinky clients. But before we even do that, we need to be really careful about assumptions, because a lot of folks who are in therapy struggle when their clinician makes an assumption about abuse when it is not happening. So I'm going to give a few examples. I would say for listeners, perhaps this is like your trigger warning, because I'm going to talk a little bit about some abusive sort of behaviors. So if we're looking at something like emotional abuse, or let's start with physical. If we're looking at something like physical abuse, and you see a client who comes into your office and they have bruises around their wrists, in a non-kink setting, if they're not kinky, that would be very, very concerning, right? You see bruises on someone or around their neck, or anything bodily, any sort of bodily markings would be really concerning. And we might, kind of put up our antennas and be worried about that and talk about it with our clients. Now, as a kink therapist, I have clients who feel immense pride in the markings that are on their bodies from playing with their partners. And so one of the things that I think is really important when someone comes into your office is recognizing, well, what kind of relational dynamic are they in, first and foremost? If they do not participate in kink, that's a lot more concerning than if they do. And if they do, I will usually inquire, but not in the way where I am assuming that it's abusive. I often will inquire more so kind of asking about, so like, what did you get up to? And like, I'm noticing there's some bruising on your wrist. What was that from? Or like, maybe I won't use that exact language, but I'll find some way to sort of comfortably have that conversation with my clients. And this is the same when it comes to language. So one of the things that's really, really important when it comes to kink play is recognizing what did someone consent to and when did they consent to it happening. So in some relationships or kink dynamics, there's what some would consider like verbally abusive language. Now, maybe that's something that is allowed in the bedroom, but is it something that is starting to be said? If in the bedroom they're welcome to say certain derogatory remarks or humiliating remarks, if that's all of a sudden starting to kind of spill out into everyday life, that's when I would get more concerned for my client. I would also get concerned if there isn't an ability to end a relationship. So there can be 24/7 dynamics, but at the end of the day, there needs to be at least enough power to end relationships. So if somebody feels that they cannot get out, that's another thing that I would be very, very concerned about.
And you had said earlier in the interview that there's this myth about a correlation between kink, whether that be action or fantasy, and abuse or mental illness. Can you speak more to that? And like, what do we know about, if anything, about why some folks really like to be restrained and why some folks really like to say things that might be considered quote unquote humiliating to partners in the bedroom?
Yeah. So this conversation is... There's sort of like the three main questions, right? There's like, when does kink develop? Why does it develop and how? And there really isn't one correct answer because there's no single research study that can confirm like this is where kink comes from. So I can talk a little bit about what some of the theories are. There's sort of these two schools of thought, the constructionist school of thought and the essentialist school of thought. And constructionist theories sort of posit that kink develops through external interests. So like environmentally, something pops up and then they see it and they're like, ooh, I kind of like this. And that's sort of where it comes from. And the sort of like opposite view of that is the essentialist view that claims that kink or interests in general come from the self. They're intrinsic parts of one's identity. And there's a few research studies that have really looked at this. The first was in 2012, where the results were kind of even. The results were about balanced, where around half said, this is a part of who I am, and then the other half were like, oh, no, it's environmental. But what I've been noticing in my, I love reading research, so what I've been noticing as I've been continuing to read more recent research, the last two studies I've seen, one that came out in 2021 and one that came out, I want to say this year in 2022, actually started to indicate that more of the individuals who were interviewed found that it was an intrinsic part of themselves. So both of those studies, and I will get you those references later, both of those studies showed that over 70% of the populations observed or of the sample indicated that their kink interest came from really just like who they are, which sort of opens up the conversation about, is kink more so a sexual orientation or an erotic orientation or just something that people leisurely do or some sort of hobby? I don't know that we're going to ever know the reality of that. Or why someone is interested in kink. So that's more so like, where does it come from, right? Does it come internally or externally? But then there's the question of why. And one of the best papers I've ever read was this sweeping review of 20 years worth of research. It was incredible. And what they looked at was essentially the last 20 years of theories about where kink comes from. So they looked at psychopathological theory and radical feminist theory and all these other theories. And then they looked at the subsequent research, assessing sort of testing out if that's sort of true or not. And every one of them did not indicate that any single one of those theories were where kink originates from. We just simply don't know. And I don't know that we will ever know or that we ever should know. Because to me, looking for where some, like, quote unquote, like where someone's kink comes from, to me is the same as asking someone like, why are you gay? Right? Like, what do you mean? Like, that's a part of my identity. It's a part of who I am. And so that's kind of how I see kink. And I know that not everyone agrees with that, but to me, I think the valuable research is more so looking at how can we better serve this community than trying to understand why they feel the way that they do.
What I'm thinking about, and I'm curious if I toss it out there, what your reaction is to it, and if our listeners are thinking anything similar. I was thinking about transactional analysis. So in this idea of the interplay between parent, adult, and child, and the different roles that we have both within ourselves and our environment, but also as we relate with other people. And so often in adulthood, when we're past what we'll call age of consent, so often in adulthood, the part that's under nurtured is that child part of us that gets to play, that gets to have fantasy, that gets to exist with a different relationship with responsibility, that can get in trouble in a different way than you can as an adult or as a parent, for example, if you're in a different role. But that it's an expression of potentially the graduating out of different kinds of fantasy from a certain age or maturity level into a different level of maturity. And that part of our identity is this kind of play.
Yeah. I mean, I think what you're talking about is particularly relevant to age players, right? If we're looking at the community of individuals who play as different ages. So maybe somebody who regresses and considers themselves a little or a middle or a big, right? These are the kind of components of somebody who is into age play. Like, yeah, I actually wrote an article on this maybe like a year ago, and how misunderstood these communities are, because in so many ways, people just want to exist. They just want to, what I hear from my clients all the time is they just want to get out of their heads. They want to give up some control for a second. Like, I think the way that society at large views this community is just, it's so broken and it's so devastating and heartbreaking when, like, the clientele and the population that I work with and the kink community in general, those who really adhere to consent and sort of the values and norms within that community, like, it's so lovely and so beautiful. And it's just, it's like art. It's self-expression, yet it's just so highly pathologized. It's awful.
So when we have clients who are open enough to talk with us about some of their fantasies, and they're just dipping their toe in the water, so to speak, how do you introduce these ideas in helping a client sort through what is consent, what are boundaries, like what does this look like, and how do I create a situation where I feel comfortable and honored, in whatever that means to me, and the person or people involved feel the same?
So I love working with sort of new kinksters. I think that's just a really fun time and in this beautiful exploration period. What I typically do, well, I'm really open. So I feel like I practice sort of an unusual way. I consider myself like pretty radical therapist. So I'm pretty open about it. And I think that psychoeducation is really kind of the greatest first step. So I will often, encourage my clients to slow down, take a breath, and start to get educated and understand the community more. So I'll give them some resources, maybe some books. I will point them in the direction of the community itself. I'll encourage them to go to Munches, which is essentially like a social gathering for kinky people in a non-kinky setting. So like bowling or arcade, something like that. So I really, really push for understanding and learning first. And then I move into the what do you not want? A lot of people don't know what they want. They sort of have some sort of inkling about like, maybe this, maybe that. But I like to look at like, well, what do you know that you absolutely do not want to do, or something that is not comfortable for you, and what the community would consider a hard limit. So something that is an absolute no. So that's sort of where I start with them. I don't necessarily have like a consent speech. I think that, when someone is coming to therapy because they want to talk about their kink, they're usually pretty invested already in maintaining consensual play because they don't want to do something wrong. I do see the opposite end of that, though, sometimes. People who've come in who are new, who, maybe were engaged with someone who I would consider like a predator in the community, where they didn't realize it was not consensual, and we sort of talk about that. That does happen. I think that people will see more clients who have experienced what I don't even consider. To me, kink and abuse cannot go together, because kink inherently means consensual. So if someone comes in and they're like, I'm in a kinky relationship where there's abuse, in my mind, the way that I sort of navigate that is, okay, well, this is somebody who's with an abusive partner. And I would do what any other clinician would do when they're working with someone who's in a DV relationship or something that's going on where it's not safe. I differentiate them so significantly, because I think that putting them together in any sort of way is just harmful.
So for you, it's being very clear with yourself and with the clients about what is abuse, what is kink. And it sounds like you start with psychoed for an early kinkster of like, here's kind of your introduction to the community. Here's some ways to learn more about it and some resources. And then you next go to, here are the hard no's.
Yes, like let's start to have the conversation about limits. Let's start to have conversations about boundaries, and let's talk about, what the standard sort of kink interaction can look like. What does the negotiation piece look like? What kind of aftercare would you want? Are you concerned that you're going to be triggered by something that's happened in your past? And if so, then we'll likely want to work through that first. Or be really conscious of that, and then also plan for what happens if you do get triggered in a kink scene. So coming up with a trigger plan. So there's sort of all these factors, and I know that it's a lot and it's probably overwhelming just hearing me talk about it, but there are resources that exist that really talk about this. Like especially like The Leather Couch, which I think is one of the best books on understanding kink from a clinical perspective and how clinicians can work with it. Like, the resources do exist. And so I think like if somebody's listening to this, or they're feeling they're feeling sort of uncomfortable, there are plenty of ways to continue learning about this community.
One of the things you said really stood out to me, which was, what if somebody's past experiences get triggered because of what they're engaging in or what they're thinking of engaging in? And it sounds to me what you're saying is part of where you see a clinician's potential role is to help identify those areas and create a plan, really a health and safety plan of like, well, then here's what's going to happen when that happens. This is how you communicate it. These are the resources that you have available to you. And that I think if I could kind of sum up what you're saying is really kink is about being very deliberate in establishing a framework of consent and safety, defined safety for what that means for the people involved. And then also creating trap doors because circumstances change and situations and context change. But that it's not like this willy-nilly kind of like, well, I'm going to use a rope tonight. It's much more deliberate than that.
Yes. If a client, and I've had some clients do that where they'll come to me and they'll have had no experience with like bondage, and they'll be like, I just saw this on a TV show and like, I really want to try it and I'm going to do it tonight with my partner. And I'm like, no. I'm really honest. Like I believe in showing up in my authenticity in a therapy room. And so I will be like, yeah, sure you want to do that? Like, let's talk about it. Because really, and this is also from Tashra's research, like the most common kink injury comes from bondage. Nerve damage is very possible. Losing limbs is even possible. Like, people have to be so careful when it comes to what they're engaging in. And honestly, one of the things that I should say I'm very biased. Like, I think that kink is beautiful and wonderful and adventurous and like, hell yeah, it's amazing. But I think one thing that I've really taken from kink and the kink community is if we could apply these ideas, and I do think this is also similar to the non-monogamous community. If we can apply these ideas of really open communication and putting extra attention into consent and extra attention into making sure we're safe in what we do, could you even imagine the type of relationships people would have? Like the closeness, the intimacy, the connection, the trust, the safety would be, I mean, it's profound and it's beautiful. And relationship closeness, that increase in relationship closeness, that is something that comes up in the research when studying people who do sadomasochistic play. So it's like, I wish that we could take these lessons from working with this community and apply it to all of the clientele that we see.
You have mentioned some words that are very specific to this community. And obviously, there's only so much that you and I can cover in an hour. For the folks who are like, okay, what was this word that she just used and how do I learn more about it? Like, what is Kink 101? You mentioned leather couch. Like, where do we go to get that information?
Yeah. So here's my standard of what I give people. Number one, absolutely. My friend and colleague, Stephanie Garlick, she is incredible, brilliant. She wrote The Leather Couch. The second version, I think it's coming out like this month, very, very soon. That's a great resource. In terms of people who want to understand or participate in kink research, Tashra is incredible. And they're the ones who are doing that new study. Actually, it's an international study, longitudinal. It's going to be incredible. And that can be accessed at kinkhealth.org. Books that I'd give my clients, the new topping book and the new bottoming book are great resources. Those are written by Dossie Easton and Janet Hardy, also the ones who wrote The Ethical Slut. There are some great people to follow on Instagram. So people who want to follow and take actual classes put on by members of the community are going to want to go follow at Kink Hub, HUB as in boy, because Kink Hub will post, sort of like repost, community classes, which I absolutely recommend that therapists take. But I do want to add that it's incredibly important to be mindful that you're a guest in a space that belongs to an erotically marginalized group. So really being mindful of that. So Kink Hub is really good. And then, gosh, like there's so many Instagram people to follow. I think it's probably best that I just give a list to you that maybe you could post for people.
Sure. We can definitely put that in the show notes.
I think that might be more helpful because I want to make sure that people get spelling right. But I think clinically, reading Sexual Outsiders by Richard Sproat and gosh, I forget the first name, but I know the last name is Hoff. I know it's Sproat and Hoff who wrote Sexual Outsiders. That's really good. And then organizations are like the Affirmative Couch. They put on courses, Modern Sex Therapy Institutes, Pink Therapy Group out in the UK. They're fantastic. There's a lot of resources, I think, if people really take the time to search, or just contact me and I will give resources. I'm always open to sharing research and knowledge and all that.
So you just gave some resources that clinicians can use to kind of prepare themselves and do the Kink 101, if you will. One of the things we haven't talked about yet, when do we refer out? How do we know that we're in over our heads? And, you already mentioned about the possibility of a client engaging in something that could potentially be traumatizing. We didn't even touch upon the idea of things that may be traumatizing to the clinician and this idea of informed consent. So how do you draw that line and kind of empower clinicians about the idea of consent as well?
So this is hard because kink is not something that everyone is comfortable talking about right off the bat. And I think that because of this, it's really important that we get as much education as we can prior to even working with the kink population. So just taking a single 101 class, a single workshop should be enough to get sort of hopefully the discomfort out in that class. So I usually recommend that just because, let's say you've been seeing someone, for a year or 2 years, and all of a sudden they bring up their kink. And if you're really uncomfortable, that could be so damaging. Or, if you want to refer out at that point, to abandon the client then also can be so damaging. So I think sort of like if somebody comes to you and there's a hint that they might want to talk about practices that you may not be super comfortable with, you want to be really, really honest and upfront. Like there are certain kinky things that I am not I don't specialize in, where if someone comes to me and they say, hey, I really want to participate in blah, blah, blah. If I don't know what that is, or I'm not, I don't feel that I have the expertise, I am not going to be, I'm not going to claim that I have some knowledge that I don't. And so I think sometimes that's a little bit difficult because we really only want to help people. It's what we do. But if something comes up that maybe like rubs up against your own trauma or makes you feel uncomfortable as a clinician, definitely seek consultation. And I would say to refer out if it's early in the therapy. If the client has taken, years to get comfortable enough to share, that at that point, I would do heavy consultation and coursework and learn, because abandoning someone who has just shared about their kink will really perpetuate their own shame. And we don't want to do that in this work.
One last quick question. When I talk with anybody who has a particular specialization, inevitably they have a different assessment procedure. If it's somebody who specializes in working with dementia, for example, it's like things that they're asking on intake. What are the things that you ask on intake that are really specific, that it's like, hey, it would be really nice if we kept this in mind? I think therapists were like, okay, what's your gender orientation? Like, what's your sexual orientation? Da, da, da. And then we move on. Like, what are the questions you wish clinicians would ask when it comes to this?
So I think because most clients some clients do talk about their kink in the beginning, but I would say that the way that I do my intakes is probably pretty standard. The only difference for me is that if someone does bring up kink, I think that I inquire, I inquire pretty specifically, because when someone comes into a therapy session and they're like, oh, I'm in this DS relationship. So what that means is I'm in a dom sub relationship. Now, that could mean anything. I think that if clinicians skip over that and they don't inquire more, they're going to have no idea what they're working with. And so if someone, I think for me, I don't have in my paperwork, like, are you kinky and how do you identify? But if we start to talk about relationships, and I make it very, very clear that I'm open to working with various relationship structures. So I'll say like partner or partners, right? Because I work with a lot of non-monogamous folks. So I actually don't talk about their kink. And I'm also really careful about my notes because kinky people are discriminated against. So I'm really careful to not write about things that can be harmful for them. Nor do I include any of that in my paperwork. The only difference is for those folks who are explicitly kinky off the bat and are in my area in LA. Sometimes we'll have conversations about if I run into them, if I'm at a conference, or, kind of what that might look like and how I behave. You hear horror stories out there about clinicians who run into their clients at like dungeons, and that's a no-no. So I think just being really mindful of that is something that I do, but I would say that my standard intake is probably not very different than anyone else's.
Thank you. But I think for clinicians who haven't worked with this community, I think there were just some important ideas that you just reviewed, and this idea of partner or partners and inclusive language. Mm-hmm. And appropriate, I guess, research and understanding of what certain terms are, and to not just gloss over that and go, I don't know, and then not revisit it. But I think those are really important highlights. So thank you. You already gave us some really wonderful resources. Elyssa, for folks that want to get in touch with you and understand more about your work, what's the best way to do that?
Sure. So if someone wants to get in touch with me, I would have them go to my website, which is elevatedhealingcenter.com. And from there, I sort of link all of my different work, my therapy practice, the like consulting and supervision work that I do. And so I think that, or so like workshops and lectures and opportunities like this, that is really the best place to reach me. Or they can follow me on Instagram at Healing with Elyssa. Yeah, those are really the best ways. And I'm pretty open to connecting. I love meeting people in this field, and I love teaching and talking about kink. And so if people want to learn more, find me and we will have Zoom coffee and we will talk all about kink.
Awesome. Thank you, Elyssa. This has been really illuminating. You have already shared so much information with us and with our listeners. And I just appreciate people like you who are talking about the topics that need to be talked about. So thank you for joining us today and doing that.
Oh my gosh, thank you so much for being open to somebody like me coming on your show. Like this is what is going to change the therapeutic community. And so I'm super, super grateful. Thank you.
You've just finished listening to another exclusive continuing ed podcast by Clearly Clinical. If you like what you just heard and you need continuing ed credits, please visit us at clearlyclinical.com to check out our 1-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.